I'm Tim Buie. I'm a pediatric gastroenterologist and autism specialist at the Boston Children's Hospital, as well as an assistant professor of pediatrics at Harvard Medical School. Before that position, I worked in the pediatric gastroenterology department at the Massachusetts General Hospital for Children for 18 years, where I was also the director of gastrointestinal and nutrition at the Mass General Hospital's Lurie Center for Autism. In addition to managing a large patient population, I have been able to publish a variety of papers and book chapters characterizing gastrointestinal problems in children with autism and developmental disorders. I serve on the Harvard Medical School Team's Clinical Advisory Board, which is targeted education autism for management across medical specialties, aimed at teaching and training Harvard clinical providers autism management strategies. I will offer a view from the clinic and what it looks like to take care of a patient with gastrointestinal issues in autism. These patients are often not able to verbally express their medical problems, and I want to try to point out how we can pay attention to what they're telling us by their presentation and behaviors. This talk will be behaviors in autism and GI issues. I want to talk today about behaviors in particular in terms of autism and children who I see with gastrointestinal issues. And I want to really spend the time demonstrating what that might look like, more than necessarily talking about the particular way that I will manage constipation or will manage acid reflux, because I think that comes along once I start to recognize what's going on with a child by their presentation or by their history. And so I'm going to start with a relatively obligatory slide, which talks about what defines autism. And anyone in the autism community is used to seeing this DSM-5 criterion, but it's a point to make to say these are kids that we see who have difficulty with their social communication and their social interactions, which makes it difficult as a caregiver to think through what is it that this child is trying to tell me. We know that these are kids who have restricted and repetitive behaviors, but I really want to focus on those behaviors or activities to see if they can be pointing us in the direction of medical issues at times. They have to have symptoms that are present in early childhood. They may get worse, and they may sort of worsen when kids are stressed. They may worsen when kids are dealing with underlying medical issues. And I think one of the factors that we deal with a lot is the idea that we're helping children with autism not be autistic, or are we helping children with autism not express the behaviors of autism quite so much if they're more comfortable. And I think that's what we're trying to work through right now. But I certainly think that we will see kids function better in a classroom if we recognize that we've handled their medical symptoms better. And to meet the definition of autism, these are symptoms that limit and impair everyday functioning. And that's what qualifies someone for the diagnosis of autism. We know that the prevalence of autism has been on the rise, and we've tracked that over the years, and it's been kind of stunning as somebody who's been in this business for a very long time to see the change in the reported prevalence. When I was in medical school, the textbook that I used was reporting a frequency of autism in the pediatric community of 1 in 5,000 individuals. Right now, as we've tracked this, the CDC reports by surveys every 2 years what the frequency of autism is in the general population. And their most recent report this year, in 2023, reports that the prevalence of autism is 1 in 36 individuals. That's a mortifying number, and it's been on the rise over time like a tidal wave. And so we're trying to deal with this problem. The newest criterion also includes a new descriptor, and that is that beyond the frequency of 1 in 36 individuals having autism, they have for the first time described profound autism, those children that have very severe features and usually have very limited to no communication capabilities. That group of patients with profound autism is about 8.6% of the total number of those kids. So when you think about that, that's about 1 in 400 individuals in the community right now with profound autism and profound communication impairment and behavioral issues. That's an amazing number, and that number alone was what the number of kids we counted with autism very few years ago. Early on, I want to think about what drew me into the community of autism over the years. And I started in practice in 1990 in the Boston area after finishing my GI training. And it was the time that there was a lot more talk about autism and the progression toward more frequent presentations. And there were a lot of different descriptive terms, and people used the term Asperger's, which has now been characterized into the autism spectrum disorder as a high-functioning individual with language and intellectual capabilities. There are other individuals who in the old days were characterized with autism spectrum disorder, but weren't characterized with big A autism or pervasive developmental disorder. Now, with the newer diagnosis, we are calling all of these children individuals with autism and trying to grade the severity of their autism by their communication capabilities or their other presentations. And so I've learned to become an autism expert over the course of these years, in addition to trying to take care of their gastrointestinal issues. And I think what I felt like I was doing in the first few years of my practice was trying to come to an understanding about what are the comorbidities or what are the medical issues that are going on in individuals who've been diagnosed with autism. And when you look back into the 90s or before, there were very, very few papers that explained the presentation of these individuals. And there were a lot of case reports or very small studies where people tried a dietary intervention to see if it improved the EEG of patients who had autism or the like. And really the data was very poor, in part because the denominator of who we were looking at, the patient with a well-described diagnosis of autism, didn't really exist at that time. And as we entered the 2000s, we were starting to get a little bit better data where we could understand what was happening with those individuals. And there were papers that were coming out describing a number of individuals, 15 individuals, 36 individuals, et cetera. And we could start to form an opinion about what was happening in those individuals in terms of their medical presentations. And as that happened, we began to work together, and by 2010, we were able, as a consortium of writers, to write a consensus paper reviewing the papers up to that date and talk about how these children presented with autism and GI issues. And that's the first paper that I list. That's accessible online. You can put that in and you can click it, and it'll take you to the Pediatrics publication that talks about the presentation of kids with autism and GI issues. And it's one of the largest first papers that talked about that as things went on. The second paper, the fourth bullet point here, is a paper with the GI doctors who were part of that consensus group, talking about their recommended guidelines based on what we understood about GI issues in autism. And we've gotten a heck of a lot better in terms of describing things since 2010 in that regard. We have tried to get a better understanding about the prevalence of gastrointestinal presentations in individuals with autism. And one of the first papers that did that was this paper by Dr. Valicenti McDermott. And she had 3 groups of individuals, 50 kids in each group. And what she found was the individuals with autism that she looked at, 70% of the children with autism had gastrointestinal issues. And she compared those to 2 other subgroups, 50 kids who had other developmental disorders, including cerebral palsy or mental retardation. About 42% of those individuals had GI presentations, And looking at the typical developing community in pediatrics, about 28% of those kids had comorbid or GI complaints as well. And so if you look at that number, you have a high suspicion that children who are coming in with the diagnosis of autism may well be having also gastrointestinal issues as well. We need to almost think about that as they're coming in because the frequency is so high. And what's happened over time is that further studies have also supported this idea. And this is a meta-analysis, which is a more scientifically based analysis than our consensus paper back in 2010 or this individual paper that looked at 15 qualified studies and pulled a much larger number of children to see how frequently they have GI presentations. And what Dr. McElhennon showed from Emory is that this group of individuals had a 3 times higher frequency of gastrointestinal issues with autism than the general pediatric population. So that first paper actually holds up pretty well, that this is a pretty common presentation and that we should be thinking about those issues. And this paper included the common presentations of GI problems that are in autism in the general community, including diarrhea, constipation, acid reflux, recurrent abdominal pain. These are common conditions in the general pediatric population, and they're common conditions in children with autism. I think one other point to make is that there's no guidance about what behaviors we should attribute to autism. We know we frequently see these things like children flapping or children bolting or children having particular responses, holding their hands over their ears. Should I accept that they're doing those behaviors because they have autism, or should I be wondering about what else might be going on with those individuals and working on the what else? And I think that's an important issue that we're all trying to deal with in the medical community right now. And so in that vein, thinking about the gastrointestinal presentation over these years, what I've wondered about is what might GI symptoms look like in an individual with autism. That high-functioning child with autism may be able to say, I've got a stomach ache, I feel sick to my stomach after I've eaten, I've got heartburn. But so many of these individuals don't have the language to explain what symptoms going on. And so there, we're looking at these communication impaired children and trying to come to some understanding about what's going on that we can interpret as a GI symptom. And I would use an old adage, which is all behavior is communication, but I would say that children who have limited communication may have the same behavior that is speaking to similar issues. I have children who've got gastrointestinal pain who hit themselves in the head. And so because they're hitting themselves here or because they've got a particular behavior doesn't mean that they're going to be communicating that the problem is in that location. And I think that's been a real challenge for us over time as we think about these individuals. I also want to say that the highest frequency of self-injury in particular occurs in 2 settings. One, individuals who are not verbal, who don't have a capability to express what's going on, are the ones who are most likely to be aggressive or self-injurious because they don't have another way to express what's happening. And the other group of individuals who have the highest frequency of self-injury are individuals who've got gastrointestinal issues. And that's been well reported now in several papers. And so we understand that when we start to see that as a behavior, especially if we see that as a new behavior, and it's not been something that's an ingrained pattern for individuals, we should be asking what's wrong. What is it that's bringing about that new behavior? And I want to give you some pictures to link to that. This is a friend of mine, and this is a capture of my screen from a telehealth visit of one of my friends who is what I would describe as posturing. You can see he's got his head turned back, he's got his arm up, and he's in a very postured position, and he will actually hold that position for a very long period of time. And early on, when we started to see this posturing behavior, we certainly thought of a very particular diagnosis, and that's seizure disorder, because many of these individuals will take on a very particular position when they are having a seizure, and then they will release and they will relax. What we've learned is that posturing can occur with other things as well. And this is a child who I made the wrong diagnosis looking at his posturing. I thought he was going to have acid reflux, and we tested him for acid reflux. He didn't have acid reflux. He was posturing for another reason. And we can talk about that later. Pressure seeking is another behavior that I really see very frequently, and I think families will speak to as a very frequent presentation. You can see this young child is holding an item and he's pushing it under his jaw, and he has to have that pressure right there, and he'll hold that item against his jaw for 20 minutes, 30 minutes, an hour, because he is getting some feedback from that pressure. And if he doesn't have that item, he's leaning on the furniture and putting his jaw up on a piece of the furniture or somewhere on the wall or the countertop. And you can see he is taking that pressure seeking to the extreme that he's actually got bruising along his jawline because he's seeking this pressure. And this is another symptom. It's not in and of itself something that gives him positive feedback. He's doing this because he's trying to sort of divert from a symptom that he has. And I would take this example and say that we've now seen this kind of behavior in a whole bunch of different ways. I have a friend who presented several years ago carrying a shoe into my office. And when he walked in carrying the shoe, I said to the mom, "What's the shoe about? I don't see many kids walk in here and carry a shoe." And she said, "Well, watch, because as we go through our appointment, you'll see what he does with the shoe." And what he started doing with the shoe was he started pounding on his chest. And he kept pounding on the same spot on his chest over and over and over again over the course of the hour that we had our clinical appointment there. And when I did my exam of that child, he actually had a callus from having banged himself with the shoe at the same location for month after month after month. When we were able to recognize what was causing the distress, the next time I saw him in the office, there was no shoe. He didn't need the shoe. He didn't need to beat himself because he didn't have the symptom anymore that was accounting for that. That child did have acid reflux, and it's something that we'll talk a little bit more about. It's not always pressure seeking, it's some other sensory issues too. I have a friend who very consistently comes in with scratch marks, and he is going at the same location with his fingernails. Or he will actually take his parent's hand and he will hit himself in that area because he needs the sensory input from someone else. I have a little girl who presented with acid reflux who had an ice cube. She would go to the freezer and she would put an ice cube in the center of her chest. And I said, I wonder if that equals acid reflux. I wonder if that equals heartburn. And I think these are the things that has really changed my philosophy. I really try to look at a kid who comes in the door with these kinds of behaviors and say, what's the mechanism there? What is the reason that behavior is happening? And it drives what I do to work those individuals up medically. Here's another picture of some people's experience. This happens to be a medical office in the bathroom, or a medical patient room in our hospital at the Boston Children's Hospital, and the bathroom. And this is a child that was in the hospital for quite some time, but he was a headbanger. And these holes in the plaster were him banging his head and needing to be stopped. And we ultimately got to the point that we put pads along the wall so that at least he couldn't break the plaster or break his head with the plaster because of the severity of his behaviors. He was a really difficult guy, and he was in the hospital for some months. We worked with every psychiatric drug that we could offer him. We worked on workup of the medical issues as well. And I think this is what sometimes has to happen. There are individuals who come into the hospital, and we have to keep working through what are the possible factors that are accounting for these types of behaviors to work them out. Many of these individuals land at psychiatric hospitals as well, and they're in those hospitals for protracted periods of time, if nothing else, else than to get enough medication to stop the behavioral events. But I ask my colleagues to always think about what might be going on medical to account for those behaviors. Here's another example of self-injury, and this is a young friend that I'm taking care of currently, and he, in the office and constantly, would just simply beat himself on his face and his eyes, and you can see the bruising and the difficulty. The extreme of this are children who will often pound their heads on the floor and on the tile, and we've had children with such severe self-injury that they've developed detached retinas and developed blindness because they've been head pounding so much that they've caused real injury to themselves and permanent injury. And these are the children that we're desperately trying to recognize what's bringing this symptom about. And we're doing both medical workup, but also medical care aimed at tamping down these behaviors, because we're really trying to save these kids' lives. They are developing concussions. They're developing brain injury from their self-injury. And it's a desperate, desperate spot. I feel very fortunate that I work at an institution where we're sensitive to this, but I know that across the country, there are many families that are dealing with this and they don't know where to go. They don't know who to deal with. And it's a real, real difficult time. This is a friend of mine who we're going to watch a behavior in action. And he is going to have an episode of posturing like we talked about before. He's eating. And so it's an interesting time to see him eating, and you could say maybe he's doing some of this behavior because he's choking or gagging, and in fact he may be, but look at what he does with his head, and look at what he does with his hands. He's got his hand on the front grabbing his chest, and we'll come around and look at that. He's got his arm up in that same posturing position that our other friend did. And I would contend that this is a posturing that often happens in acid reflux because it's used as a way of trying to help swallow things down, help clear the esophagus. And we'll talk about that a little bit later. But this is an episode that for this young man was happening many, many times a day. And it was happening very consistently with when he was eating or following eating, but wouldn't happen at times that he didn't have something that he was trying to put into his stomach. So that posturing for me was a red flag to think about underlying medical issues, but he also had other extreme behaviors. And one of them was his self-injury. And I am desperately sad to watch him have this response. And I think you can see he's just miserable. And he's a nonverbal child who his mother is a wonderful advocate in the autism community about using communication tools as an alternative to those nonverbal children, as we're talking about in this series. But even he, with those benefits, is in misery. And we really struggle to try to get to what's going on for him. So I think, although I talked about the prevalence of gastrointestinal problems in autism before, I'd like to revisit that issue and say that after seeing these images, and these are children who are not coming in and saying, "Doc, I'm having difficulty swallowing. Doc, I'm having heartburn. I'm having stomach pain after I eat." All we're seeing are what we would call problem behaviors. And these problem behaviors are a nonverbal response to pain. They're not specific. They might be happening with migraine headache or dental pain or other factors, but they're the only thing that I've got to look at to say, I need to do a little bit more work to figure out why this behavior has come on in this individual. And I think that because we're seeing these kinds of presentations, I don't think we have fully expanded the number of individuals that we see to know what the real prevalence of gastrointestinal complaints or problems is in this community. That is an ongoing mission for me. How do we include these kids who are only giving us nonverbal cues? Let's talk about a particular condition, and you'll hear more about this in one of our other talks as well. Back in the early days, Dr. Horvath reported 36 individuals who he was doing endoscopic evaluations on because they were actually presenting with chronic diarrhea. And he reported that in those endoscopies, 2/3 of them had esophagitis, which I think was a surprising finding for him as they were presenting with a different type of a symptom. And then we watched and we tried to gather more data about this, but there were very few papers over the course of the next many years that could characterize what were the endoscopic findings of these individuals. And we had difficulty because we knew in our patient population that we had a very skewed patient population. We were dealing with this issue called referral bias. And so when we would talk about how frequently we would see these problems, we knew that we were biasing and probably seeing a higher frequency than the general pediatric community. So not until very recently have we had data to look at to really support that this high finding of esophagitis is real. Sonia Bilal, who's going to be presenting in this series, has just published a paper. In fact, it will be in print in January of 2024, but it's available online in the Journal of Pediatrics right now. And what she described were 3 patient populations. She had a very large patient population of individuals who underwent an autism, had an autism diagnosis and underwent endoscopy, over 500 children. And she had 2 other groups of patients, children with gender and age match who had developmental disabilities, and children who did not have other medical issues who underwent endoscopy. So we had a large population of individuals to compare. And what she showed in that study was that there was a higher frequency of esophagitis in this patient population with autism than in either of the other groups of kids who were undergoing endoscopy. We're going to spend more time talking about this with Dr. Bilal in our other talk, but I think it's really important that she also demonstrated that this higher frequency of esophagitis in this population means that these kids are really suffering and we're not recognizing it. And we also have to recognize that not all kids who have acid reflux will have damage from reflux. They won't all have esophagitis. In fact, perhaps less than half of them will have damage from esophageal reflux, so that we have to really be thinking that many more of these individuals may be having these symptoms without presenting with esophagitis and giving the red flag to the treating physicians. Back to posturing, what we did with a friend of mine many years ago was that we were able to demonstrate for her that her posturing episode exactly correlated with when she was having acid reflux. And we did this by doing a test called the Bravo pH probe, which is a wireless device that we place in the lower part of the esophagus, and it measures acid reflux over time. So we're able to look at those individuals over time and correlate their behavior or their presentations to the time that they're actually having symptoms of acid reflux. And we were able, in her case, to say that every time she had this posturing episode, or almost every time, she was having acid reflux. And it made it so much more helpful for us to say, this is where we need to zero in. This is not a pure behavior. This is not avoidance and trying to get out of your classroom or trying to stop what you're doing. She would take this posturing position in her sleep at times. And so we knew that it was triggered by a medical event, and we were able to prove for her that this was acid reflux. Using that same technology with my friend that I demonstrated originally who was posturing, we actually demonstrated that he did not have reflux at the time he was posturing, and it helped us come to a different diagnosis for him. By excluding reflux, we were actually able to show that when he was posturing, he was also doing air swallowing, and he had this condition called aerophagia, which is consistent with his diagnosis. So even when we exclude acid reflux or exclude some of these conditions, going through the diagnostic steps is sometimes very helpful in how we get to taking care of these people. This was Joanna's esophagitis, the girl who was posturing, and you could see she had evidence of chronic damage. She had acute areas of bleeding from acid coming up there and doing damage. These are individuals who are in pain, and they're not necessarily saying, I'm in pain, but these behaviors are happening, and as behavioral therapists, we've been trained often to say, put your hands down, get back to work, stop acting out, when we should be saying, honey, what's wrong? What's going on here? Why is this happening? We may not be able to ask it of them, but we should be asking it of ourselves. Certainly the most common condition that we take care of in the autism population and in general pediatric GI is constipation. And I wanted to talk about this just beyond saying that constipation is common, is to get to what constipation looks like in this population. So constipation can be defined as stool infrequency. And if there are children who are having stools that are less than once every other day, that would meet the criterion for constipation. If they're having harder or what are called skibbolous pellety stools, that might meet the criterion for constipation. Or if they're having difficulty passing stools or what's called dyschezia, that would meet the criterion for constipation. What many of our children with autism meet the criterion for is this condition called functional fecal retention, where they are actually attempting to avoid going because they know they're going to have discomfort. And they've become fearful of the event, and so they become less frequent than their typical pattern would be because they're trying not to go. And ultimately, there's so much stool buildup that we'll see fecal soiling, or we see kids who are actually reaching in and trying to get stool out of their rectum through digital insertion to get stool out at times. And then they smear, and we say, what a horrible behavior, these kids are smearing. And really, they're trying to say to you, I can't do this. I need help getting my bowels regulated. And we see all the time individuals who've got fecal smearing or digital insertion that if we can get their bowels regulated, they stop that behavior. And I think it's really important for us to key in. One other thing that I think is really important is that that's not just unique to autism. This is a problem that we see in kids who've got attentional issues, ADHD, et cetera. These are kids who sometimes don't have enough attention to be able to go into the bathroom, listen to their body, give themselves enough time to actually have a successful event. And we think about the average Joe who's sitting drinking a cup of coffee and then needs some time in the bathroom. These are kids who may go into the bathroom, spend 30 seconds, and then come out and they're done. Well, that's not how the effective process works. And we sometimes have to really program these kids to recognize, I need to go in, I need to have time, I need to be able to get into a comfortable mode to do this. And even I need to get to the step of where I go to the bathroom is in the bathroom and not somewhere else, which is my place of comfort behind the bed or in the closet. So there are a lot of steps to getting to success, but we have to start somewhere and we have to recognize that there's a pathway to go to. Food allergy I mentioned earlier, and I would comment that food allergy is more common in the autism population. We know in the general pediatrics population, the frequency of allergy is about 7 to 8% right now, based on several studies. The studies that have looked at food allergy in autism report about a 15% frequency of food allergy. This is really important because, again, children with food allergy will present in a number of ways. Certainly, we know to recognize food allergy when a child eats peanuts and they develop hives. But many children with food allergy will present with vomiting, or they will present with constipation, or they'll have abdominal pain issues, and that's all they'll demonstrate as their marker for allergy. So at least keeping the idea that screening for food allergy is extremely important. And we've gotten very specific at our institution to say, look, we need to be more particular about which kids try dietary restrictions because we're losing so many nutrients if we put these kids on a milk-free or a milk-free gluten-free or a milk-free gluten-free soy-free X-free diet. We really get to the place that we've highly restricted them from nutrient values. And that's not to say that some individuals may not benefit from those diets, but we want to help by doing the evaluations to help decide what's real and what can we say works for these kids. And that entails somebody who's really interested in working through diet with you. And that includes a nutritionist and includes a gastroenterologist or an allergist. And so I think we're getting better and better as we recognize food allergy in this population. And as we get better, we're a little less wide open with doing dietary restrictions when we probably shouldn't be in everybody. Earlier in this series, Julia Carmody has presented avoidant restrictive food intake disorder, and she's talked about how children with autism present with restrictive eating. What her study shows, or what this discussion talks about is that 13% of individuals who've been diagnosed with ARFID have autism. We know that 2/3 of individuals with autism have picky eating as described by their parents. And so that selective eating pattern is extremely common in this population, and it's really important that we focus in on how do we break out of some of that pickiness for these individuals. We also know that going the other direction, children with autism have ARFID frequently. And so if you take individuals with autism, about 28% of them will have avoidant restrictive food intake disorder. And so I think this is an amazingly common problem, and center to center, these problems are dealt with very differently. And so I think we're coming to the place where we're recognizing that we need to develop some more national guidelines and some help for communities that don't focus in on feeding as much as other centers. So we'll have more on this, but I am really excited that there are caring providers who are working on this problem right now. And I think that as we go through these problems, we understand that recognizing the underlying medical issue will drive our management. And so in the old days, I would talk about what are the things I would do to treat acid reflux, what are the things I would do to treat constipation, what are the things I would do to deal with feeding disorders. I think it's much more important for you as a watcher to say, what's the problem that I want to deal with for my child? I want to get that diagnosis. Is it acid reflux? Do I have the possibility that this is an allergy, et cetera? And then we can develop an algorithm for the care that we can provide for these kids or these adults who we may find it. And you need to do that in a center that is autism friendly, that are people who recognize that taking care of individuals with autism is an added challenge. And they're not going to come up and tell you what to do. They're going to give you a list of problems that you've got to help them work through. And so you often have to decide that you've not married your provider, that you have to date around a little bit till you find somebody who's right for your child and for their needs. And I think that's okay. None of us will take offense with the idea that we may not be providing the best care for your child's needs. We want you to get to the right people as well. And I think that's getting better and better. There is a national interest in practically every field, neurology, psychiatry, gastroenterology, sleep, et cetera, where we're focusing on establishing guidelines to do a better job by taking care of this population. One way that we're doing that is a model at Harvard right now called TEAMS, which is targeted education of autism management across medical specialties. And these are specialists in autism who are teaching trainees what we do and how we recognize these problems and work on them. This is coming out soon. It was sponsored by Nancy Lurie Marks Foundation. God bless her and her family, who have done an enormous amount of things for autism. And I think that you'll see this coming out originally for the Harvard curriculum, but this will be used and shared in other medical training communities. And I think it will have application broadly. What you have to do until these pathways come out is engage in partnership with your own physicians. And I think that your pediatrician should be your best ally. And a good pediatrician will say to you, I don't feel comfortable helping to manage this, but I'm going to get you to someone who may help you. And that may be a good nutritionist, a cherished gastroenterologist, a wonderful developmental person, but they need to help you get to the partners that you can work with to establish the right care for these problems. And I think that's the way to go. And that's the way to go no matter what state you're in, what country you're in, and whether you have a world-class institution down the street or not. So many of us do not have that fortune. I have so many people to thank. I have a lot of gratefulness to the people who came here together at my request to come and do these presentations for you, and I'm so grateful to them. Tricia Woods did a lot of our coordination and helped us to bring this to production, and I'm so grateful for all that she's done and support that she's offered over these years. This series was funded by the AIND Foundation, which has been focused on bringing education on medical topics to autism nationally. And they are wonderful, and I'm tremendously grateful for their support over many years. And finally, I just have to say thank you to the families who've really taught me what to do by bringing their children to me and trusting me to do my best for them, sharing their photos, sharing their videos, sharing their ideas, their knowledge, and sharing their children so that I could do a better job taking care of other children, so that we can all do a better job taking care of other children. Thank you for your attention.